into disc edema, there are two types. One is pseudo disc edema and is true. So a pseudo disc edema is basically when you actually feel there is an elevation of the optic disc but without any exoplasmic stasis. The most common cause what we encounter is optic disc drusen. The others being anomalous vessels or vitropapillary traction. The congenital ones being morning glory syndrome. So coming to optic disc drusen, this is most commonly seen. If you see a disc edema, do tend to do an autofluorescence. We can save a lot of time for yourself and as well as for the patient. So always do an autofluorescence, and that will actually pick up these hyper autofluorescent bodies on an autofluorescence. If you don't have an autofluorescence, do try to do an OCT, and it will actually show presence of these small low signal regions with overlying or surrounding hyperreflective bands, and it is basically present above the lamina diffusa. And if not, then do an ultrasound to actually pick up these highly echogenic posterior acoustic shadowing. So once you definitely, if you can do this, you can say that to the patient that it is not an problematic condition, and we can actually follow up these sort of patients. So coming to a true optic disc edema, how that is different from the pseudo one. The most common being here there is an elevation associated with exoplasmic stasis. There is an elevation of the disc which could be actually appreciated on a slit lamp ophthalmoscopy. There is associated peripapillary nerve fiber edema with peripapillary hemorrhages. There is congestion and hyperemia of the optic disc with peripapillary folds, and maybe it would be associated with subretinal fluid. So if you have an unilateral optic disc edema, you have to ask for any visual symptoms, whether it is blurry, scotomas are present or not, if the patient has any headache, if there is associated horizontal diplopia, and do rule out chances of meningitis with history of fever, neck stiffness, and etc. And then you can do your routine visual acuity visual examination, look for the fundus for associated inflammation, and see for changes of the vascular changes, whether it is attenuation or sheathing of the vessels. So true edema could be, it would be in the process of developing. It could be unilateral or asymmetric papilledema, and it could be the cause is increased intracranial pressure, which we normally encounter. These sort of patients, if you try to do an RAPD test, and in these patients you would not see in the apparent visual function will be normal. There will not be any RAPD. So commonly we see this benign intracranial hypertension. If you see a patient who is having bilateral disc edema, the most common cause is BIH. It is usually seen in female of childbearing age. Patients may come with complaints of headaches, pulsatile tinnitus, horizontal diplopia. You may ask for history of any medications. You do an visual field that would have enlarged blind spots or arcuate defects. You have to order an MRI with MR venogram, that is most common for a patient who has bilateral disc edema. It is important because the MRI will pick up the signs of intracranial placed ICPs, that is flattening of the posterior sclera, distension of the optic sheet, and partially or complete empty stela. MR venogram should be done because it does pick up venous sinus thrombosis in most of the cases if the ICP is not raised. So treatment is weight loss and giving acetazolamide to these patients, and it does resolve over time. The other entity is optic perineuritis, and the cause would be infection or an autoimmune cause. The other cause which we see could be an optic nerve sheath meningioma. So this is the algorithm where you have a unilateral disc edema. You have to do an OCT or an autofluorescence to rule out drusen, and if it is not drusen, then definitely do an MRI with an MR venogram to see for abnormal imaging and normal imaging. And if it is an abnormal neuroimaging is there, the underlying causes could be papilledema or optic perineuritis or meningioma, one of the causes. And if it is normal, then we have the most common entities, which I'll explain further. That is NAION. These patients will have disc edema. They will have acute onset loss of vision. They would have uncontrolled hypertension, diabetes. They will actually have, if you look at the disc closer, they will have segmental or diffuse disc edema. And over a period of time, this will actually eventually go into pallor. The other cause could be inflammations. Central CRVO is something which we commonly see. There is a hyperemic disc with associated attenuated vessels with hemorrhages all around extending towards the arcade. You do an FFA if you want. You can see that there is delayed AV transit time with leakages at the macula. Diabetic papillopathy is also one of the differentials where you can see there is disc edema bilaterally. There is an diabetic patient which is uncontrolled, and you do an FA which will show leaks. This is also optic neuroretinitis is also seen where you have disc edema associated with macular exudates in a stellar pattern. This is what it is, and these patients would have underlying inflammation or maybe infective pathology. So for a bilateral optic disc edema, first you rule out whether it is true or not. So do again I'm repeating, do an autofluorescence or an OCT or an ultrasound, then followed by if there is a true disc edema, try to do a brain MRI with venogram and then follow it up. I have saved this slide for the last because this is also what we commonly see. We have a patient who comes with disc edema with hemorrhages in the peripapillary area with associated exudates, and these are the patients we actually do an MRI. But if you actually ask for do a routine blood pressure of these patients, we'll definitely come up with a grade for hypertensive retinopathy. So you can save some time for these patients also. Thank you.
Thank you very much. It's a nice presentation, Doctor.
With Dr. Dipinder, because what, as he rightly said, the implications of disc edema are very severe. So you would want to treat a patient with disc edema after ruling out neurological causes rather than vice versa. That you first do your treatment and not responding and then send to neurologist. So I think first things first. So here probably before you start doing a workup on ophthalmological causes, sometimes if you see disc edema, you would probably first want to rule out any other major life-threatening issues involved. So, which is why I think I agree involving a neurologist or ordering a scan should be not an especially these days of medical legal issues and everything. You need to be sometimes careful on that. Yes, Dr. Paritosh.
All the different the gamut of cases discussed today in this session, for the comprehensive ophthalmologist, again, an important take-home point is documentation. And to do fundus photography, you don't any longer need a hi-fi fundus camera. You just attach a small adaptation to your slit lamp, or even on your phone you can do that. So please document all these cases with whatever gadgets you have. Because comparison, as already pointed out by some of the chairpersons and the speakers, it's very important. And from medical legal perspectives also, it's very important. And from your own learning perspective also, it's very important, because there are some cases you might end up seeing maybe once or twice in lifetime.
So it's an obviously inflammatory disease that you are seeing and disc edema is part of it, then doesn't make sense to order an MRI. But if it is in isolation, I think you would be very careful.
Thank you very much, Dr. Awaneesh.